channel. And if you have any question, feel free to put it in the Q&A in the chat, and we'll address it at the end in the Q&A. And thank you for being here, Dr. Fraser, and feel free to go ahead and start.
Well, thank you so much. And hello, everybody. Let me see if I can make this more clear. I wish we could all be together in person. I'm assuming that folks are joining in from a lot of different places around the country. Is that true?
Yeah.
Is everyone here in the United States, or do we have some from overseas?
Y'all can put in the chat where you're from. We do mostly United States, but we do have a couple from other countries as well.
Okay, cool, great. Well, I guess there are some benefits of the pandemic. Although there's someone from Ireland. Fabulous. Yeah, I've done a lot of these talks over the last 18 months, and it's really fascinating to be able to talk to people around the world all at once. So that is, as I said, a bit of a benefit. So I thought I would just start out telling you all a little bit about who I am and what I do. It was shared with me that the majority of you all are either still undergraduates or maybe in graduate school. I don't believe many are in medical school. Is that fair? Looks like I don't see anyone saying they're in medical school, but I'm assuming that the plan for everybody is that they want to get into medical school. So that's great, because the world certainly needs doctors, and maybe now more than ever. And you don't have to be you don't have to look far to find out that there are a lot of problems, a lot of healthcare problems that need bright students like you all, need bright people, passionate, committed people to find solutions for. So thank you for your commitment. It's a long, arduous journey at certain levels, but it's also enormously gratifying. Not gratifying, excuse me one second, I'm gonna close my door so no one interrupts us. And I counsel a lot of students, and which is a great privilege of mine. In fact, it's one of, other than being a pediatric heart surgeon, probably my greatest professional joy comes from mentoring students who become medical students, who become residents, who become fellows, who become my colleagues. So it is kind of part of our sacred oath as physicians to train our successors. And I've always felt that was really core to my identity as a healthcare professional. Some of what I am going to tell you, I apologize if it seems a little elementary, but I always want to make sure that people understand kind of what the pathway looks like. So in North America, to be a practicing physician, generally we're talking about 4 years of medical school. I think there are a few programs that you can get it done in 3 years, but mostly 4 years. And as opposed to in some other countries around the world, in the United States, most people have finished, a baccalaureate program somewhere. And I believe there are many of you all that are in graduate school. So, for example, at our Dell Medical School here in Austin, quite a number of our medical school class have had other careers, including having other postgraduate degrees. So there's not, in my mind, there's not a absolutely mandatory pathway. People often ask that, do you have to do this, this, and this to be a doctor? It is kind of standard, as I'm sure you all have learned, that people go into some sort of science-based degree, pre-med, pre-dental, biology, chemistry, sort of, it almost becomes a little bit of a garden variety approach, and that certainly can work. But I know a lot of really good doctors who have fine arts degrees, who have had business careers and then decided to go into medicine. And at certain levels, having an education in business can be really helpful to you as a physician, just because it is the reality of medical practice if there is a business side to it, wherever you end up working. So in any event, high school, undergraduate school, plus or minus some advanced degree, then medical school. So then after medical school, you apply, or during your last year of medical school, you apply for a residency. And a residency is variable length depending on what specialty you choose. And some of them are very long. So my residency training, and I include residency, my fellowship in heart surgery. So my residency training was 9 years after medical school. And during my time as a resident, I spent 2 years in the research laboratory because I was interested in becoming an academic physician. So that's also something that's very confusing for people. I work and have for my entire career worked for a medical school and worked in a hospital. It's certainly not the only pathway that people take. You know, there's private practice, there's group practice, but I've always worked for a medical school. So my paycheck comes from the University of Texas, and where I am a tenured professor. And so during the course of my now 30-year career, I have taken care of lots of patients. And again, that's my core identity as a professional. I teach constantly. We have residents and fellows and students. We have a medical student on our service right now who's learning and participating in patient care. And then I also conduct research and publish a lot. And, you know, just part of my professional identity to participate in trying to create new knowledge and disseminate that knowledge. And so sometimes that's writing papers, sometimes that's speaking at national and international meetings, sometimes it's doing things just like this, which are enormously valuable. So again, just to clarify, it's funny, even my own family sometimes ask me, and I don't have, other than one son, I don't have anybody that's in healthcare. They would say, well, do you take care of patients or do you teach? And I say, well, I actually do both, and always have. So anyway, that's kind of the pathway. And so if you want to be a surgeon, you've got to take a long path. If you want to be a cardiologist, you've got to take a long path. And in the United States now, to be a cardiologist, it's usually 3 or 4 years of internal medicine and then a 3-year fellowship in cardiology. And most people these days are subspecializing beyond their basic program. They're doing some focused area like electrophysiology or rhythm disorders or interventional cath, where we put catheters into the heart to correct problems. And so that can be at least another year. So again, we're talking 7 or 8 years after medical school. So it's a lot of commitment. And it's all building blocks. And it's all enjoyable, but definitely hard. One thing I always say to young students is, if you're going into medicine because you're driven by the dollar, you're making a mistake. Now, certainly physicians can earn a very nice income. It's very probable. Not to say it's easy to earn that income, but you can have a nice quality of life from the standpoint of your compensation. However, in my estimation, it wouldn't make sense at all to go into medicine in terms of the time commitment relative to the remuneration. It would be a real mistake, and it would be probably very disappointing for an individual to have that be their goal. And it can be a little bit insidious, so you have to think really hard about that. What's going to give you, as an aspiring healthcare professional, what's going to give you the most gratification? My advice is, if you don't feel stirred in your soul, and I mean that sincerely, if you don't feel stirred in your soul to take care of patients or contribute to the well-being of the healthcare environment, it's probably not going to work out well for you. If, on the other hand, you're driven to learn new things, take care of people, and help society be better, then it's an enormously gratifying life. And one of the things that is kind of maybe even overlooked is that once you become a doctor, once you graduate all this heritage, you're still a student. You're a student for life, constantly. I mean, you can't see my desk, but it's stacked full of journals and things, and I'm reading stuff all the time. I still have to take exams, believe it or not. So my board, I have 3 different board certifications: general surgery, cardiothoracic surgery, and pediatric heart surgery. And they're kind of staggered, and they have to be renewed every 5 to 10 years. So I'm constantly studying for exams and whatnot, but keeps you hopefully vital, and certainly participating in the education of students keeps us on our toes as well, because we have to provide a good platform for the students. So anyway, so I was talking to a college student this morning, actually, who came and spent time with me, and then came to our rounds. And she asked me, how did you end up being a children's heart surgeon? And a lot of people ask me that. And in fact, I never, first of all, I didn't really even know there was such a thing. So I see some really good questions coming up, and we've got 1 hour. Is that right? Probably 1 hour. Okay. So I'll make sure I'm watching the time so that I can get to as many questions as possible. But in any event, I'm just speaking about my own personal experience. I'm not saying it's right or wrong, but I never planned anything in my career. I never planned a single thing. I didn't decide until my junior year in college that I was even going to go to medical school. I wasn't probably the most accomplished student as an undergraduate. I did a lot of fooling around, probably too much sometimes, but in any event, I thought hard about going to medical school and kind of had some epiphanous events halfway through college, and decided I didn't know that I was going to be a surgeon. I went to medical school with an open mind, and frankly, I enjoyed all aspects of medical school. I could have seen myself being I like nephrology or being a kidney specialist. I was very interested in burns because we had a big burn unit in my medical school. I went to the University of Texas Medical Branch in Galveston. And so there was just a whole diaspora of things that intrigued me. But what really caught me was when I was on our pediatrics rotation, and when I was in medical school, we had a very busy pediatric service, general pediatric service, that took care of patients with all kinds of infections and trauma, basic things and not so basic things. But we had this one little child, and I believe she was about 5 or 6, and she had a really bad injury. In fact, she had a gunshot wound there was an accident, and really tragic accident, but she was shot in her bottom, in her backside. And fortunately, it didn't injure her bowel or her rectum or any of her private parts, but it took the soft tissue right off the side of her bottom. And I can remember when she came in, I was on call with a young general surgery resident, very smart lady. And it was just this terrible looking wound in this little girl. And we didn't really know what to do. And the chief surgeon, who was over all the pediatric surgery at that time, was out of town. So we admitted this little girl and we put her in the ICU bed. Because of the injury, we had to put her prone, front down. And just this big deficit in her backside. And we were talking, we're going to have to do plastic surgery and skin grafts and all kinds of things to get this wound to heal. And Monday comes around and the surgeon, who really was, he probably doesn't even know how much influence he was on me way back when. I think he's still practicing, but in any event, he came back in town, he looked at it and he said, this will be fine. This will be just fine. So we're going to put a little covering over it and we're just going to let it heal. And lo and behold, we gave the child good nutrition. We put this little plastic covering over it, and the wound just it did take a few months. It just shrank down and it healed. Now, it left her with a pretty substantial scar, but she had no disability from it at all. And I just remember thinking, this is like a miracle. I mean, how can this possibly happen? So I became intrigued with the idea of operating on children and looking after their needs. It was also quite clear to me that if you operate on a child who has a critical problem, you could be conceivably, altering many, many decades of life. And I'll share with you some pictures about just that reality in my own career. And it's enormously gratifying to see someone that you've had today. I operated on a child that's 3 days old. And she will, I hope, outlive me by a very long time. So anyway, that's why I got interested in pediatric surgery. I went to my residency to become a general pediatric surgeon. And during the course of my residency, I was shown to have an aptitude for heart surgery. Some people saw some promise in me in terms of my technical abilities and interest. And so my career sort of was a marriage of pediatric surgery and heart surgery. And my focus became on children's heart surgery, or the majority of my focus is on children's heart surgery. And so that's been my career. But there was no plan to it at all. And that's continued to be the case in my professional life. All the places I've been to, I just followed my nose. What seemed to interest me the most and challenge me was what sort of drove some of my most important decisions. So let me see if I can make this work on the share screen. I'm not nearly as adept as you guys are. No, see if I can make this work. There we go. Okay, can y'all see that? Yes. Okay, so people often ask, why pediatric heart surgery? Why does somebody even have such a job? Well, in fact, heart disease in children is the most common birth defect by many orders of magnitude. Roughly, more or less, 1 out of 100 babies have a serious structural heart problem when they're born. And about a quarter of those babies, so 0.25%, will need heart surgery in the first year of life to live. So that turns out to be a lot of people, a lot of children. Interestingly, if you go around the world, the incidence of congenital heart disease, pediatric heart disease, So congenital means you're born with it. So the incidence of congenital heart disease around the world is pretty much the same. So whether you're, a mother's in a developing country or otherwise, the incidence is about the same. The types of diseases are a little bit different. And that's interesting and in large degrees genetically linked, although we don't know the genetic causation of all congenital heart problems. So it's a common thing. A lot of children are diagnosed these days during pregnancy. So you all know that in the United States, most mothers have a screening abdominal or fetal ultrasound at about 16 weeks of pregnancy. And what the ultrasonographer is looking for is, does the baby have a 4-chamber heart? And you know, our hearts normally have 2 sides. We have a right atrium that collects the blue blood from the body, which drains through a tricuspid valve into a right ventricle, pumps the blue blood out to the pulmonary artery that goes to the lungs. The blue blood delivers carbon dioxide and picks up oxygen, then it becomes red blood. It goes through the pulmonary veins to the left atrium, which drains through the mitral valve to the left ventricle that goes to the body. That's a normal heart structure, or normal heart morphology. So the ultrasonographers look and see, does a fetus have 4 chambers? And if they don't, or there's some uncertainty about that, then they will refer the pregnant mother to a fetal cardiac specialist, which is typically a pediatric cardiologist. And then they'll do more imaging and can very accurately diagnose problems during fetal life. So the little girl on the slide here, I've known since she was 20 weeks gestation. It just so happens that she's now 9 years old. And this is a picture that, and her mother and father are very dear to me, and they send me pictures on her birthday and when she starts school and all kinds of things, which I really appreciate. But in any event, this was a photograph of Olive after I had done heart surgery on her, and she was born with transposition of the great arteries. So the arteries were reversed, and then she had a bunch of holes in her heart. So the condition she had without treatment is fatal. And it's something that we take care of a lot. I have a very large experience with an operation called the arterial switch operation. And basically what we do is we reverse the arteries and put them back in their normal physiologic connection. And we do that in newborns. So that, of course, is enormously gratifying. This young lady also has transposition of the great arteries. And to, again, emphasize one of the things that's been so cool about my career is this young lady is 26 years old, and she basically showed up in my office one day to say hello, wanting to meet the surgeon that operated on her when she was 3 weeks old. And I hadn't seen her since she was discharged from the hospital at that point. She lives in another state elsewhere in the country. So you can imagine how gratifying that is to see someone going ahead with life in a grand fashion after starting off life with a really, really bad problem. Again, these are the kinds of folks we operate on, little babies. And so you can see on the screen there, this is a little baby after heart surgery with an incision covered by bandage, breathing tube down in the windpipe. There's a little drainage tube in the chest. And people often ask, how is it you operate on little babies' hearts because they're so small? That is true, but we have the right gear, the right tools, and there's a whole cadre of specialists that I work with who focus their career on patients like this. So surgeons, nurse technicians, scrub nurses, people that run the heart-lung bypass machine when we're working inside the heart so we can support the circulation. Those are called perfusionists. Critical part of taking care of a child like this is anesthesiology. Very, very different to put a critically ill newborn to sleep as opposed to an adult. So a lot of specialists involved in the care of the children. And then after surgery, well, cardiologists do a lot to care for the patients before surgery, and they also can do some procedures with catheters and things to benefit the babies. And then they help us take care of the patients after surgery, along with intensive care doctors and ICU nurses and all sorts of people. So it does take a real village to take care of children like this. Now, I wanted to share with you all a little bit about my own personal journey. And one thing I would like to encourage you all to do, because you're writing your own story. Everyone on the Zoom is writing your own personal story. And I wasn't as good at this as I might have been, but I did start keeping really careful notes about things as I was finishing college. And some of them were very technical. You know, during the course of my residency, when I was learning something new about a particular operation or something, I would try to diagram it. And I do think that's a principle that's important for a surgeon. Generally speaking, if a surgeon can't draw the operation, they're going to have a hard time doing it. But sort of chronicling your pathway will be interesting to you someday when you look back on it, because you'll find that you have a lot more insight into things than you might perceive. And in fact, some of your insights could be the pearl that changes medicine. You know, you may have an idea that seems crazy to solve some very difficult problem that turns into a monumental advancement. So I encourage you to take a lot of notes. However you do that, if you do it electronically or by hand, it really doesn't matter, but take some time and contemplate what you're doing. And another thing that I recommend you do, now, of course, you all have social media. You've got Facebook and all the other platforms to keep track of things, but make a concerted effort to pause, if you will. Take a pause and look around you. Look at the people that are your classmates, your colleagues, your friends, your professors, because it goes by like that. And what I find a lot of students doing, which I did myself, but I advise you try to combat, is you become so project oriented. So I gotta get A in organic chemistry. I gotta get A in physics. I've got to get this score on the MCAT so I can get to medical school. I got to get these letters. Every summer I've got to do research, so I get my CV looks good. And I'm not saying that a lot of that's not important, but while you're doing all that, your life is going by. You know, you guys probably remember who John Lennon was one of the Beatles. He said, life is what happens while we're busy making other plans. So I find a lot of students become so project oriented that they don't smell the roses along the way. So word of caution. 1 year turns into 10 years, turns into 30 years, like that. Probably your parents have all told you that too. Well, these are the places that I got my legs, if you will, in healthcare. So starting in the left upper quadrant of the screen, that's the University of Texas Medical Branch, where I went to medical school. That's a famous building. That's called Old Red. That's the first medical school building in Texas. And it's actually the oldest continuously operated medical school west of the Mississippi River. It's a really fantastic building. And if you're ever down in Galveston, which I encourage you all to do, go and visit. If you're really thinking you're going to go to medical school, go visit the medical schools. Take the time, drive, go see, wherever you are in the country, go and see the medical school. But it's a fascinating building, and the top of it, of course, this building was opened, I think, in the late 1880s. I should know that, but I don't know exactly the date. No air conditioning, and so you can see really high windows, and the top floor was the anatomy labs, and there are vaulted windows on pull chains that they could open so that all the odors of the cadavers could go out the top of the building for the students. And I've seen some old pictures of that. It's really fascinating. Right next to it, to the right, is Johns Hopkins. And one of the miracles of my life was that I got to be a resident, again, for 9 years at Johns Hopkins. And interestingly, Johns Hopkins and University of Texas Medical Branch are about the same age. Actually, Johns Hopkins is a little younger than the University of Texas Medical Branch. But it's a storied institution, transformed my viewpoint on medicine and commitment. And I'm eternally grateful to Johns Hopkins. Then going to the right, the top right of the screen, is Royal Children's Hospital in Melbourne, Australia. And it was suggested to me by one of my mentors as a resident that if I really wanted to be an outstanding pediatric heart surgeon, I needed to travel, take my family, and I had a young family then, to Australia. So we moved there, and it was a eye-opening experience, and it really changed my trajectory. And then after that, I came back in the left lower quadrant, and I worked at the Cleveland Clinic in Cleveland, Ohio, one of the best hospitals on earth. And that building sort of dominates the photograph, is the Heart and Vascular Institute at the Cleveland Clinic, which is the #1 heart and vascular institute in the United States for more than 20 years running. And it's a phenomenal place full of phenomenal people. And then in the right lower quadrant is Texas Children's Hospital, which is the primary academic pediatric affiliate hospital of Baylor College of Medicine. And I joined Texas Children's and Baylor College of Medicine in 1995. And we built a whole new heart center, heart program. And as Suha said, it was a very successful venture. I share this not to proselytize. This could be taken either in a religious connotation or a secular. And so that's not for me to say, but I will say that I believe that these words are important. Along the course of time, a lot of people, a lot of institutions will be investing a lot in you. And because of that, much will be expected of you. And I will say it even more emphatically. Society needs many of you. Maybe not all of you end up being doctors, but we need you to make good on the investment that these institutions make in you. And it's, I think, a solemn responsibility. Now, I'll just spend a few more minutes and tell you about children in a different context. You probably know, but it's worth stating that even in the throes of a terrible pandemic, the #1 health problem in the United States, the #1 killer, is heart disease. You might also know that our success in mitigating the effects or preventing heart disease. Now, I'm talking about things beyond congenital heart disease. I'm talking about acquired heart disease, hardening of the arteries, coronary artery disease, valvular heart disease, heart failure, things that adults get. Despite spending literally trillions of dollars on the treatment of heart problems, we're not making as much progress as we would like. So for example, the life expectancy for adult men in the United States over the last several years has either been flat or actually gone down. And the number one problem is the heart. So I share this with you because we need people to be interested in heart disease. And hopefully some of you all will be impassioned by that reality. Heart disease is an ongoing societal problem. And we could talk ad infinitum about causation and some of the realities of our lives. But one that to me is very poignant is that children, so now I'm talking about children who are born with normal hearts. The children who are born with normal hearts, if they aren't looked after properly, proper diet, proper exercise, the stage is set for heart disease as early as kindergarten. And it can mean that their lives will ultimately be shortened, the quality of life will be lessened. And I'm sure you all know that things like diabetes and respiratory problems and heart disease are intimately related to poor eating habits, obesity, and it's a serious societal problem. So this article was published in one of our most prestigious journals by some very prestigious cardiologists, and Dr. Valentin Fuster at the Mount Sinai Hospital in New York City, and he is an internationally renowned adult cardiologist. He takes care of people with adult problems. Isn't it interesting that he wrote an article about children? Because he gets the same concept that I'm alluding to, and that is promoting health in children will translate into early and sustained well-being, better diet, physical activity, body awareness, emotions. This translates into better communities and better public health policies. It's a difficult group of concentric circles, but the reality is, in my estimation, undeniable. So we came here to Austin now a little over 3 years ago. Many of you all probably know that Austin has become one of the most attractive cities in the United States. It's just grown exponentially over the last decade or more. Home of the University of Texas, and I'm an alumnus of the University of Texas, but until the Dell Medical School opened, there was no medical school in Austin. There was no medical school associated with the University of Texas. So having the opportunity to work and help build a new medical school and new programs is really what attracted me and quite a lot of other people to come to Austin. And we're about going together. We know that in healthcare, although individual performance is important, the performance of the team in an integrated collaborative fashion really is the way to optimize patient and societal benefit. So this is the new medical school building, what we call the health learning building. It's a different approach to medicine. It's still a 4-year medical school. It's a small school, 50 students per class. They're really outstanding students. And again, it's part of the integrated University of Texas campus, which offers myriad opportunities for research and collaborative programs. And then this is where I work. This is where I'm sitting right now. This is the Dell Children's Hospital. We are the primary teaching affiliate hospital of the University of Texas Dell Medical School. We have a very busy hospital. I think we've got about 30 children in the hospital right now with complex heart problems. And I, as I said earlier, I operated on a newborn today with hypoplastic left heart syndrome, which is a very, very bad heart problem. It's a problem that's uniformly fatal without treatment. So that's what we do. And we operate pretty much every day. So I'll be operating tomorrow as well. This is the operating room when we got started. And again, this is part of our professional gratification. This was our first medical student who scrubbed with us on a case. This is Taylor Taliaferro, who just matched in obstetrics gynecology after medical school. And she's going to go and do a residency in that. I very much believe that Mandela had it right, that if we focus on the children in society, probably that will solve a lot of ills. And we don't always do it to the best of our ability, but hopefully we'll, as a community, continue to do better and better. But this is just a little snapshot of some of the patients that I've taken care of over the course of my life. This is an interesting one. A guy in the green, I operated on him when he was a little child, and then he had a baby. So that's pretty cool. And this is who we are with the Texas Center for Pediatric Congenital Heart Disease. All right, so I'm going to stop sharing, and let's look at some of these questions.
I can read out the question for you, Dr. Fraser.
Okay, that would be really helpful, Suhas. Thank you.
Of course. Okay, so first question will see, how do you manage to balance out the varied demands of being a doctor while also managing to study and continuing your practice? What drives you in your profession and your specialty?
Well, I would be the first to admit that I do not have a balanced life. And I haven't had a balanced life for about as long as I can remember. Now, I'm very blessed to have a wife that has tolerated me for 38 years. And she's been an enormous support to me. I haven't always been as respectful and grateful to her as I should have been, but I can tell you I couldn't have had a family had I not had a wife who was able to shoulder a lot of dual parenting responsibilities. I do have 4 now grown adult children, but my life is not balanced. I spend almost all of my waking hours at work. I came this morning a little after 6. I'll be here another couple of hours after we get off this Zoom. That's just what I do. And I will say, for my world, you can't really do it well and do it part-time. You have to kind of be immersed in it. Now, there are other specialties that are very, very important specialties that don't require probably the same time level of commitment. But anyway, I don't know if I'm giving you all good counsel or not, saying what I'm going to tell you, but by and large, physicians become pretty well, their identity really becomes their profession. As unsavory as that might sound at certain levels, if you're a practicing physician, it's very hard for your family. Now, you can make time and be very strategic about your time. I will say that when my children were growing up, I was tenacious about getting to their important events and things, but I've been for some long days. So anyway, I don't hold myself up as some paragon of balance.
That's really impressive, managing to keep up the stamina to do all that work. Another question is, what should one take note of doing clinical rotations in medical school to help them decide what residency to apply to?
Yeah, so that's a very important question. And, I think it is actually a challenge with all medical schools. And that is, you've got a student that's come in, hopefully the student doesn't have too many preconceived ideas about what they want to pursue. And then there's this whole portfolio of opportunities, pathology, radiology, obstetrics, pediatrics, cardiology, orthopedic surgery, rheumatology, dermatology. And how do you do it? Well, it's not easy. And I'm not sure it's always done perfectly. So what I always tell medical students is to be very, very possessive about your time in medical school, because it goes by so fast. You've got a lot to learn. course, you've got all the basics that you got to learn. You got to do well on the exams, et cetera, et cetera. But you also have to be very inquisitive because you can't possibly do all the rotations and all the different things. So, for example, when we have people that come to our rotation in surgery, I'm encouraging them to go and see what the cardiologists are doing and the anesthesiologists are doing, and the intensive care doctors are doing, and the nephrologists. Go and at least explore a little bit, because you might miss something that would be really intriguing to you. And there's some really cool specialties that are very, very nuanced. So, for example, a neurologic interventional radiologist. Maybe some of y'all already knew such a thing existed. This is a radiologist with special skills with catheters who can thread little catheters through your arteries up into the arteries in your brain and take care of problems like retrieve clots if you've had a stroke, or block off aneurysms, or maybe help treat a brain tumor. Who knew that there's even such a specialty? It's one of the coolest things imaginable. I mean, it's like rocket science. It is rocket science. So anyway.
What are some of the most difficult cases you've come across?
Most difficult cases?
Mm-hmm.
Yeah. Well, it's probably not really apparent, but we operate on a huge variety of problems. It's disturbing to think about how many things can actually go wrong with the heart when you're developing, but a lot can be abnormal. So we have children that half their heart is missing, or valves are missing, or arteries are missing, or veins are missing. We pretty much have solutions for most of those problems, but the most vexing problems are when the squeeze of the heart itself has deteriorated to the degree that the heart can't manage. That's called heart failure, if you will. And you might realize that people can receive heart transplants, but and children can receive heart transplants, but there aren't many donor hearts available for children. That's probably on the one hand a good thing, because some child has to die to become a heart donor. But when children have heart failure, that's a really, really difficult problem. Sometimes we can put machines in to support their circulation. They're called ventricular assist devices, but that's a very challenging category. And I mean, I could tell you, hundreds of stories about patients that have come to us in desperate situations that many times we're able to save. So that's part of what we do.
The next question we have is, does there ever come a time where dealing with the lives of children becomes more overwhelming than you may think another surgeon had to deal with? So I think they're like talking about like it become overwhelming dealing with children's lives in surgery.
Well, at certain levels, it's always overwhelming. I mean, I although I'm very experienced and well down the track in my career, thousands of operations, I still become very anxious in a controlled manner when I approach a difficult problem, or frankly, any patient that I'm operating on. And I actually think that's healthy. I think that you have to have a respectful degree of trepidation when you're submitting to someone that you're going to do an operation on them in the name of making them better. To say that I get to the point of being overwhelmed in my profession, well, maybe sometimes even I'm not aware of it, but it's probably more in the realm of making sure that I'm not too tired and well rested when I do things. And that is part of the learning as a medical student and a resident, is how to take care of yourself so you're performing at an optimum level. And we do work hard at that.
As a physician remaining active in research, what do you believe are significant breakthroughs or development in pediatric surgery that medical students today will get to experience during their lifetime?
In pediatric surgery, or just generically?
Pediatric surgery.
Well, in my field, again, I think there's from the procedural standpoint, there's still a lot of room for quantum leaps and things like valvular heart disease. So replacing valves in patients, that's a very big problem in children. It's a very big problem in adults. So that's an important area needing focus and advancement. Heart failure, we talked about earlier, and ways to support the failing circulation. Very important avenue of need and need for focus. I think if people are inclined towards the medical side of things, being non-surgical, preventative cardiology, and dealing with those societal concerns that I alluded to earlier. I mean, these are sobering realities. I mean, I hope none of you all here smoke. If you do, stop. And I mean smoke anything. I'm not saying that from a standpoint of, again, proselytizing about mind-altering medications. I'm talking about what smoke does to your lungs and what smoke does to your cardiovascular system. It's terrible. It's like the worst thing that you can do. And I can tell you, when I operate on a child who comes from a family of smokers, I can see it in the child's lung. It's enormously disturbing. So these are problems that aren't talked about enough. Now, it's fortunate that, generally speaking, the society of the United States has by and large become very critical of tobacco use, as they should. But nonetheless, I see young people smoking, and it's so disturbing because the things that you do to yourself when you're a youngster, or even worse, that a youngster is exposed to innocently, could set the stage for a disaster for the rest of their lives. So anyway, hopefully you all are ambassadors for good health. That's a good thing.
Absolutely, Dr. Fraser. How often do you stay with patients after they're 18 because you performed on surgery on them as an adolescent and they feel more comfortable sticking with you?
A lot of, I operate on a lot of patients that I've cared through their lives. So I have a lot, probably in a given year, between 5 and 10% of my patients are adult patients with congenital heart disease. So I have a lot of patients in that category.
Another question: if you had to pick a specialty apart from pediatric, which specialty would you pick and why? Something that's not pediatric related.
Well, I probably would still do surgery. I'm kind of an immediate gratification guy. I like to see a problem, fix it, see the result. I think hand surgery usually means anything from the fingertips to the shoulder. I think it's fascinating. Our hands, I mean, think of all the things your hands can do. I mean, these are amazing tools. And so when things go wrong with the hands, that's a big problem for patients. So hand surgery is very, very interesting to me. I think neurosurgery is fascinating. Neuroanatomy and being able to do things to help people with neurologic problems, brain tumors and things. That's fascinating. And enormous progress has been made in neurosurgery. So that would be another field that I would probably have gravitated to.
With more innovations in minimally invasive procedures, are you seeing a decline in the amount of people that are becoming cardiothoracic and cardiothoracic/heart surgeons?
Well, yes, we have seen a downturn in interest in cardiothoracic surgery over the last 15 or 20 years. It kind of ebbs and flows, but we need more heart surgeons. That's true. Unfortunately, people still need heart surgery. Now, heart surgery today in 2021 is radically different than when I trained in the early 90s. It's like almost unrecognizable, but people still need heart surgeons. So hopefully there'll be some intrepid souls that want to take that on for a career. It's a very gratifying one, but it's different.
Thank you. Interesting question. Someone said they see the book Outliers on your desk and that they love that book and they want to know what are your favorite books to recommend to them.
Well, I read all kinds of stuff. I actually haven't jumped into that yet. Someone gave it to me. I'm right now. I'm reading a, really a biography on the Comanche tribe that was native to Texas, and very interesting. Something that I've been interested in a long time. So I read a lot of history. I don't know what else of late. As I said earlier, much of my reading at night is medical literature, so maybe I'm a little boring for you guys.
Thank you. If anyone, I have this one more question I'm going to answer from chat. Anyone has any question they want to have Dr. Fraser answer, you can feel free to unmute now and speak. If not, I'll answer one more question from the chat and then we'll finish for today. As a student that's interested in cardiology, what do you recommend the student to like go? If you're a student interested in cardiology, what activities do you recommend them to pursue throughout their journey?
Well, as an undergraduate or even a graduate student, before medical school, you're certainly encouraged to try to, go and do observerships, go on rounds, just kind of get in there and watch and see what's happening. Go to the cath lab, the heart catheterization laboratory, go to clinics, just see, listen, go to conferences. And then in medical school, if you're really interested in that, really focus on some rotations that get you hands-on experience with heart patients. And I might even think about spending some time doing research in cardiac disease. And there's plenty to do.
All right. Thank you so much, Dr. Fraser. That is the end of our time, and I know you have a busy schedule. Thank you for taking your time out. Your journey as a pediatric and congenital cardiothoracic surgery. Very
Well, you're very welcome.
very
Very
inspiring.
welcome. Thank you all for your interest and keep up the great work. Bye-bye.
Right. Thank you all for attending our session today. Our next session will be on the 30th with Joshua Cools, a flight paramedic and a critical care air transport paramedic. And we hope to see you all today on that day. Thank you all.